All right, here we are. Woo, 2 minutes late. Sorry about that. It's hustling here, trying to get ready for our 6 o'clock. And we're going to talk about some fun stuff today. I'll give you guys a second to roll in. Give everybody a chance. It's a beautiful Thursday here in Michigan. We got sunny skies. Everybody is happy, good moods. We love it. Hope you're in a good mood too. Hope this is going to be useful for you today. So we had started last week talking about, we took a lot of questions. First of all, thank you so much for being here. Those of you that were here last week, thanks so much. It was a lot of fun. Took a ton of questions. This week, I brought up this paper that was about, I'll show it to you real quick. Let me pull it up here. Right here. I'm going to use this to control it. So we have this paper right here that we talked about, the differentiating between the structural and functional instability of the cranio-cervical junction. And I think a lot of people are interested in this topic and it resonates with them. So we are going to talk about it today. I put together a little brief, kind of fun way to go through it. I kind of made it a little simple. We're just going to talk about the 7 ways neck joints affect your brain function, the role of cervical joint errors. So thank you so much, Irene. The Fairzuck, I hope you're home, settled in, feeling great, and ready to have some fun today. Megan, the Suze would like you to know she is here and ready to party. Eileen says hello. So I really appreciate you guys saying hi. I know that way I know you're here. I actually have no way to know if you're here without the chat. So if you don't mind, send that over to me. Let me know you're there. Just a little wave or something fun. Dennis wants to know, will forward head posture / computer neck be addressed? I probably won't call it that, but that's kind of what we're going to talk about in a way. So I think if you're interested in that, this will be a really useful talk for you, for sure. Big Arm, welcome back. Glad you're here. We'll just hang out and listen. I appreciate it. Thanks for being here. Little housekeeping. You guys let me know in the chat. Hello, Michelle. We are thinking about starting next week because 6 o'clock sometimes is a little bit hard for our people here to get to. Europeans, I know that it's about as late as it can get for you. Hello, Kathleen. Nice to see you. But we are thinking about moving next week and doing a little trial on an 8 o'clock Eastern time stream. So let me know what you think about that. We may give that a little run and see if that's a little easier for people to find their way there. The Europeans, I know that sucks because that makes it really late for you guys. Corey, good to see you. Elisa, good to see you. And then Big Arm says there's 17 people. I can see the number, but I can't see who is here. So I appreciate that. So yeah, if you want me to notice that you're here, say hello. I really appreciate it. Makes it fun. So let's dive in. So 7 ways. We're just going to make it, I made it super simple, kind of made it easy to digest, and then maybe we can even walk through some of the ways we look at it here to detect the role of cervical joint errors in people that are feeling what you feel for a lot of you. Alicia said, just finished crushing some monsters. Face fuchsia, tongue. Nice. I like that emoji. Beautiful. Well, thanks for being here. So let's do it. Let's talk. Let's see. I've got this hooked up to my iPad so I can draw today. So that's the paper. If you guys are interested, I shared it last week. It's a 2024, I believe. There's been a ton of work in this area, so it's not like it's the only one, but it's a really great paper and just kind of getting started, and it's kind of refreshed and a little new, so that's always kind of nice as well. Amy, hello from Washington. Thanks for being here. Courtney, pumped for this topic. Love it. So let's do it. Here we go. So why your neck matters more than you think. This is an odd one. I am obviously trained as a chiropractor. I kind of have a special affinity for all things spinal, But the reason that it's important is because it's the conduit that's basically carrying all of the information and just like vascular capacity from your head to your body, from your body to your head. That's all traveling through your neck. So it's kind of a big deal. And most of our body serves to just carry our head around. So our head is like, if you think about where the main sensors are, like most of the really, really, really special senses, like our 5 senses, live on your head, right? Sight, smell, taste, auditory sensation, but then also even just like being able to communicate, and whether that's with your facial expression, whether that's your speech, or whether it's even like using your eyes as a way to communicate. So your head is like arguably one of the most important parts about you. So when we think about that, it's got to be pretty specialized, not only in the way it's acting as just a tube, but in the way you move it. So in other words, you got to be able to move your neck and control where your head is orienting, right? So if there's a bear over here, I want to quickly be able to get my head over there accurately. But then I also need to do that without messing up other stuff along the way. Cool. So this paper in particular, so I want to be clear, this particular paper is the core feature. I'm just kind of going through it, and then I'm just interpreting it, making it a little bit easier. So not everything it says is going to be like my perfect take on it, but it's going to be, I'm going to just try to present this and then give you some of my information on it as well. Okay. So I think an important part to know is the top of your neck isn't just about movement. It's deeply connected to how we process information. And what I mean by that is really simple. There's so much proprioception, and maybe I should define proprioception first. Proprioception is just the idea of knowing where something is at. So if you take your finger right now and you bend it, in your mind, even if you don't see it, you can feel that happened. And then even if it's still, you know where it is. And that's the idea of proprioception. So it comes from your joints, comes from your muscles, comes from your skin, but it tells you where things are. So if you can imagine, we're getting a lot of information about where things are at any given time. And some of the most dense fibers in that, or some of the highest resolution, happens right at the top part of your neck. So it's really, really important. So it makes sense that if you happen to have maladaption in this area, and what I mean by maladaption is just like it's not working right. The sensors aren't working. So if it was your phone, you'd like be smacking it or holding it up in the air. That can happen in your neck with different types of problems. And when they misbehave, you can have a lot of different types of symptoms, and I'll explain a little bit about why that is. But basics of it is that we don't live in a linear world as far as our neurology goes. Your nervous system is designed to take separate receptors and combine that information so that you can use it to make meaning of it. So just really simply, if you think about even just you watching this broadcast right now, you're sitting here, your head is going to be generally vertical if it's healthy. Your neck is going to be straight. And then wherever your eyes go, your head's going to kind of aim. Like if you've ever seen, the camera people riding those big cameras at a football game and the chair kind of swivels, right? You can think of your head as being the turret that swivels your eyes around, and then your eyes can make the adjustments to be able to move around within that range. So this kind of changes the field of view, and then our eyes can move around in that field of view. We fully take that for granted, and we expect that it should just kind of be there. But when you have an injury to this area, or it's just not behaving in some way, then we can see that those errors shine through. And usually errors that we have in function, the way we feel them or interpret them is through a symptom that we feel. Something doesn't feel right. Something's not working right. Okay, so I won't belabor that anymore. Let's roll. Number 1. So 7 things that are important. Number 1, your neck joints, if they don't work right, they can confuse your sense of balance. So the mechanoreceptors that feel where your neck is, they tell you where your head is in space. So if they're wrong or faulty or too slow or too big, like the signal's too amplified or it's too small, then I'm going to get the wrong signal about where my head is in space. And if I don't know exactly where my head is in space, the sensation of that is, generally speaking, dizziness. Dizziness can mean a lot of things, but it's basically a problem with your felt perception of where your head is, and that can make you feel unsteady, and it can even make you feel nauseous or like you're motion sick, okay? And this happens because if the joints aren't giving the same signal as your eyes or your inner ear or even the other joints, or in some ways you might have joints that don't communicate with the muscles correctly. So if any of these things start to create a mismatch, it starts to look like things that mess with your balance. Why does that happen? Well, it happens because where this is all processed together is in one area of the brainstem. And I don't know if I pulled a picture up or not, but that area of the brainstem is called the vestibular nuclei. And in the vestibular nuclei, so let me do a little art class here. So let's picture this as your brainstem. You have these kind of little nuclei. They're in fours, so I kind of draw them like diamonds, even though that's not perfectly accurate. But these nuclei take in information from your ear. Sweet looking ear, you're welcome. They take in information from your eyeballs, right? So where they're located in space and also what they see. So that information comes down as well and gets integrated. And then also from the proprioceptors that we just talked about, the mechanoreceptors in your neck. So let's make a little muscle here, right? So these little muscles, those are going to talk in here as well. So basically you can think of this. It's a little stretch, but it works for the purposes. Is these are all electrical signals, right? So those electrical signals are kind of like a language. So you can think of it as I have like a muscle language, which means that electricity travels at a certain speed, certain pace. Looks like a language. My eyes give a certain language, and then my ears give a certain language, right? And what's being done here is those languages are all coming into this area that's a hub, and we're creating this multi-sensory processing. Meaning, I'm going to take all of those signals and I'm going to turn them into a unified signal. I'm going to make them generally the same. So I'm going to put them into the same language. So I got 3 different languages. Now I'm going to put them into the same language. That makes the coding a lot faster. It's like making this little zip file. And if I can do that, now I can transmit that information more quickly and it's unified. So at this level, I can send it back and forth, side to side, so I can corroborate the 2 signals from the 2 different sides. I can use that to create reflexes that are going to go straight back down on autopilot. And then I can use it and I can send that up to my brain to tell me more information about where I am in space. This is all done without really any cognitive input at this point. This is all just sensors being ripped up there, all getting processed together, and away you go. So you should be able to see then how you could run into a problem where if any one of these signals doesn't match the others, my signals are going to tend to affect that balance system, which is going to include things with your vision. It's going to include things with your balance sensors in your ear, and it's going to include things that control the motion of your neck, which is pretty cool. So if that makes sense for you guys, just give me a little thumbs up. Let me know if you got a question. Let's see. But that's the point I want to make really clear, is that we have to look at all of these signals as like opportunities to, one, make more clean inputs into the system, or it can have the opposite effect where it can kind of screw up how all these things integrate in time. Okay, I'm going to take all this away and then we'll go to the next slide. Done. Okay, so next slide. So number 2, neck joints confuse your sense of balance. Number 2, vision becomes unstable. So your neck helps to stabilize your eyes as part of the vestibulo-ocular and vestibulo-colic reflexes. So vestibulo-ocular means that when I turn my head, my eyes will tend to move equal and opposite to the head movement, no matter where they go. And as long as those signals are being processed cleanly, my eyes will move correctly. So the place that you might experience this is like, hey, I turn my head really fast and it feels like there's like a comet going behind my eyes. Like my vision just has this big comet behind it. Or you might feel like if you're running, the world is just bouncing like this, right? So, because your eyes aren't stable, they don't have that stabilizing mechanism that goes counter to your head. And that can feel really disorienting. The second thing that will happen is when that becomes unstable, you get the initiation of a vestibulo-colic reflex. So vestibular. Colic is actually neck. Think like my collar, right? So that vestibulo-colic reflex, if my eyes aren't stable when I move my head, and I'm going to feel like the world's moving on me, it's going to make me dizzy, it's going to make me sick and disoriented. What I will then do is, without thinking about it, your brain will kind of constrict or lock down the muscles of your neck, makes them really rigid. And it does that so that you don't move your head so much, so that your eyes aren't being whipped around because the vestibular reflex is lost. So if I've got problems with that vestibular reflex, there's a high likelihood that I'm going to feel rigidity or stiffness in my neck movement. Some of you that have seen me before or have seen me work know that one of the ways we look at that is just simple at the bedside. I'll just put my thumb up and say, point your nose at my thumb, and we'll have them turn their head. And what I'm looking for is when they're turning their head, their eyes should stay right in the middle of that movement. And if I can do that, it means that number one, I can suppress my VOR. But number two, it means that my neck and my eyes are coordinating. So it's a way that we can go a little step further and be able to understand, is this a problem in the processing? Is it a problem in my neck? Why is my neck stiff? Is it because of a reflex from my eyes? Or is it because I had a whiplash or something like that that's actually injured the tissue in my neck? Or both, okay? So why? Okay, so now I've got this problem where both my neck or my ear can cause my vision to be unstable. And if your vision's unstable or blurry, or you notice like it's weird when I look near and far, like I've got these changes in the reflexes of my eyes. That's another common one I guess I didn't bring up, and I don't think I wrote it here, but the same way we can have these reflexes when we rotate our head, we also have them just in gravity. So just me sitting here, I have reflexes that hold my eyes at level. But if that reflex changes in my ear or the integration from my neck, it can screw up the level of my eyes. And if I screw up the level of my eyes in this way, I can also screw it up going fore and aft, forward and backwards. This shows up a lot for people that have a hard time creating different depth fields with their eyes. Like I can look at my phone, but when I look up, it's like my eyes don't focus right away, or I get weird, or I get nauseous, or I feel pressure in my head. So we'll notice that, and we'll say, look near and then look far, and we'll see their eyes are moving funny. And then you might feel those kind of strange sensations in your head. So all of these things are different ways that that vestibular nucleus, if it's not able to integrate the information very well, is going to cause this type of symptom as well. So visually based symptom. Cool. So at this point, though, you could look at this and say, we don't know if it's the vestibular system. We don't know if it is I'm actually going to see if I can pull these side by side. We don't know if it's the vestibular system. We don't know if it's the neck. We don't know yet at this point, but we know they're capable of it. And so often, if I have visual problems, where's the first place I'm going to go? I'm going to go get my eyes checked. But we may see that may not be the origin of what's happening. And sometimes we'll do things like say, like, oh, we have like a binocular vision disorder, which just means my eyes don't work together, which is fundamentally telling you, and I say this with a little bit of passion, it's fundamentally telling you that there's a mismatch happening in the projections to the vestibular nuclei. It's saying at rest, when your eyes are just trying to be still, something else is messing with that signal to the point where it's causing your eyes not to line up correctly. Okay. Very, very, very important, because this is a super common thing that you'll hear about. Okay. I'm going to take a moment, and before I go on to number 3, looks like we've got some comments here. I'm just going to go through them real quick. I got from the Fairzuck. He's asking, does training your neck muscles help like a Formula One driver? Training your neck muscles can help. Specifically, when we think of training neck muscles, we think of two things. Like the main one is like, can I get them strong? That's what we usually think about with training, right? I'm going to get this big football player neck, which can be really useful. But in addition to just having like a big, linebacker neck, even more important is, can I control my neck? And when I say control it, do all the joints move the way they're supposed to as I operate my head? And can I control like my eyes and my head together? And can I control the way that my shoulder and my head work together? And all these things start to stack on top of each other. We see pretty commonly also where we have injuries to the shoulder and neck that even moving your arm can start to make people have symptoms in their neck, which can then make them dizzy or nauseous or make their eyes blurry. Okay, so it's a really good question. You just wanted to talk Formula One with me. I know you, but I appreciate it. Danielle, thanks for the shout out on the good information. Let's see here. Okay. Could this affect reading and handwriting? You're pronouncing my name fine. You asked about it last week. Ailsa. 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 We're going to try that, like sail. Ailsa. So we're going to flip sail, Ailsa. So affect reading and handwriting. I would say, so I wouldn't say that all reading and handwriting problems are this, but yeah, absolutely. So problems, so we're talking about neck here, but what I'm trying to show you is the bigger question is how are all these things talking together? So you imagine them like siblings and they all have to work together. And if they don't work together, it messes the whole team up. So yes, can it affect reading? Absolutely. It can affect the way that you're positioning your eyes. It can affect the way you're tracking. Can it affect your handwriting? Absolutely, because we start to look at these coordinated efforts here. Does that mean that's the only thing? Not necessarily, but it's a good place to start. It's a good place to start. Okay, let's keep going. How can you determine if your neck is causing the problem? Great question. We're going to talk a little bit about that more as we walk through it. But right now we're kind of laying the groundwork for how these things talk together, how they're a team. And then later we're going to differentiate specifically around when these joint mechanoreceptor errors are happening. Good question. Let me get back to that one. Stay tuned. This is like our preview for the next episode. Nomad over normal. I like that name. Thanks for doing this. I appreciate that. Try to see your picture there. Can't quite see it. It's tiny. And then Amy, could this be a cause for trying to get up-to-date prescription for my daughter's new glasses? Okay, maybe. Let's talk just briefly about prescriptions. I don't want to step on toes for optometry. It's a wonderful field. I love it that people can see. I think you should see clearly. One of the things we notice is that after head injury, we can see people that had normal vision all of a sudden feel like they need corrective lenses, or they might change, or with autonomic problems, we get sick and all of a sudden our vision changes. And the question is there something that's wrong with our eyes, or is there something wrong with the processing or the control of how our eyes work together? I don't know, maybe you guys have you seen these cameras where they do 3D, like make movies in 3D, but it's actually multiple lenses. And that allows you to be able to have depth. And that's probably why we have two eyes. I don't know. I wasn't there when we made them, but it's a reasonable thing to assume. So in order to have depth or to be able to see in 3D vision, we've got to be able to have two eyes and they got to be able to work together in tandem. And what we can see sometimes is when we interrupt these pathways, we kind of disrupt how they move in tandem. And that can create different eye positionings. Or if I have, let's say I have this eye positioning at rest where my eyes, one is like a little higher than the other. But then I can use my vision, and if my vision's off, it'll be like, oh, that feels terrible. And it'll try to like use your vision to kind of make up for it. But this takes a lot of energy because I'm actively pulling those eyes back to neutral. And then when I rest or if I'm tired, those eyes might slide back out of position. Most of you know what this feels like if you've been there, because it's the thing you do where you get tired and your eyes just kind of like blur out on you. And then you can see that happen as you create the eye drift. One of the most popular tests is where they'll do a cover uncover, where we'll cover an eye, have you look straight ahead at a target, and we'll uncover it and we can see the eye move from its other location. And then you know that that's where it wants to rest. And when you do that, it's a pretty good signal that the ability to hold that binocularity is off. And if the binocularity is off, then there's a high probability that something is wrong with the way you're perceiving information about where your head is in space, from your eyes, your ear, your neck, or if there's a problem in the pathways that connect them. So that's one way to think about prescription, is the actual position of your eyes. Number two is we see another common variant that we see is where we start to see changes in perfusion to the eye, or the blood flow that goes to the eye, that can cause an eye to feel dim or blurry. And when we see that, you can actually kind of test between eyes. And sometimes we'll be able to do things where we just touch places or manipulate your neck in a way, or move your head, or have you squeeze a hand, and all of a sudden your vision comes back, right? And these are really useful. You can just like squeezing the trap, you'll see the blood comes to that eye, and then all of a sudden you can see clearly again. These are really kind of simple bedside tests, but they're really helpful. And just to take a moment, we're actually working on, Ginny and I, and Dr. Claire Keiser, the pretty one, are working on a project right now where we're trying to build out a way. So here's the deal. We notice that a lot of the calls that come in are people that are having to wait like absurd amounts of time to get any sort of real testing, particularly in orthostatic intolerance, right? POTS, orthostatic hypotension. And the easiest way to look at it is on a tilt test, because you can find out pretty fast, but it's hard to get the test. And we know there's a NASA lean test that is kind of like a hack at that. And so what we've done is we've kind of looked at how do we look at a tilt test, and then how can we start to add in some of the modifiers to a NASA test so that we can make it a little bit more useful for people at home. So that's a project we've been working on. We're going to make available just with a like simple PDF, but here's how to do it, and video, here's how to do it, so people have access to it. And this is one of the things that we see is those changes in visual acuity that can come with these autonomic problems. You're going to see that at number 4, little heads up. Let's see here. One more from Nomad Over Normal says, would you say it's worth looking into when the subject eye skips going right to left at around the 10 o'clock mark? And headaches on that side of the head. Normal docs say, yeah, not a problem. So I think what we're saying is, if we're looking in the eye is, so we're going right to left. So this is my right. So right to left at about the 10 o'clock, we get a little skip. And this would be kind of like in a pursuit. And in that pursuit, oh man, we're getting deep. This is like, it's like teaching a doctor level class. This is kind of like my home, so bear with me. So if we think about those, and that pursuit has an error, now we're coupling what is happening relative to the vestibular system, or the VOR, and we're going to couple that to what's happening just with a visually mediated eye movement. So where I'm just using my vision, I'm not necessarily moving my head. And those two things have to go together. But they both rely on the same mechanism that is called a retinal slip mechanism. So we're getting off topic, but we're going to talk about it because I want to. How's that? It's fun. So the retinal slip, let's look at it like this. So in your retina, let's make your retina purple. So the back of your eye, we got a retina. Okay, so if I look in, like, we'll do a fundus exam, we're going to look into the back of the eye. We're going to see your retina back there. And inside that retina, you're going to have your fovea, and that's where you see, that's where all the light's getting sent, is to the fovea. So in the fovea, you kind of can break it down into 3 areas. Most of you may remember you've got rods and cones are the 2 main like photoreceptors, and they detect slightly different things. So in the middle, you have the cones, right in the middle, and that's where the fovea is, and that's where you see clearly. So that's really dense with these cells that are really good at seeing clarity, like high resolution. That's in the fovea. That's where you see clearly. So like if you stick your thumb out and you focus on your thumb, and then you put your other one behind it and you really stay focused on that thumb, the other one's actually becomes a little bit blurry in the periphery. Same like when you're reading. And then around this, kind of like a little bullseye, we have a bullseye area here. That's the parafovea. It's not nearly that big. I made it way too big, but it's more like a little band. And this is kind of like the gray space between the fovea and then the peripheral visual field, the peripheral retina. And then so we could say like the peripheral retina is everything else, but it's got some of these rods that are mixed in. And then out here, it's mostly dense with rods. And these rods are really good at detecting like changes in movement, right? So if something happens over here, well, what is that? It wants to detect things that should change our visual reference point, meaning like if something's happening over here, getting my attention, that's what your peripheral retina is good at seeing. That's what your peripheral vision is for. So now I can redirect and then put my clear vision on top of that, right? Cool. So you can kind of think about this though. When I'm tracking something, as I'm following, I'm using that peripheral retina in a lot of ways. So you can almost think about it like I'm going to change this drawing a little. I made way too many lines. Let's go like this. Oop, brings it back. Okay, that's not what I planned on. Okay, so the way to think about it is you imagine like I've got that fovea and I'm trying to keep it on my target to keep it clear. That's what tracking is. But if I do that, I have to have some way to know that what I'm tracking, like when do I get to the edge of it? If you've ever looked through binoculars, like following something, if I'm following, like a football game, soccer for Fairzuck or a Formula One, and I get to the edge of my binocular, I know that I got to move my binocular to center it back on my target, and I can kind of move them together like that. So it works the same way in your fovea. So if I get toward the edge, there's like a warning track. If you've ever been to a baseball game, that dirt part around the outfield that tells the outfielder you're getting close to the wall, right? So if I'm looking up at a ball, I can feel that dirt under my feet instead of grass, and I know I'm getting close to the wall. That's kind of what we have. We've got this little warning track, and that allows us to make sure that once it gets in toward the edges, starts to hit the warning track, that signals that I should move and try to keep it in the center, keep it off the warning track. And if we're good at that and that processing is fast enough, then I don't ever lose a pursuit. I'm able to stay on it. Life is good. But if that slows down and I'm not able to detect the change fast enough and I can get through the warning track, then I'm going to have a little jump that causes my eye to jump forward, right? So if I'm jumping forward toward the target, then I know I slipped off it and now I got to catch up to it. That might be what you're talking about here. If that's true, then now we're looking at a visually mediated thing. And then I got to see, is there also a vestibular one? So when I turn my head, does it also happen? So I turn my head and fixate in the same way. Do I also see the same jump? In which case I know that there's an error in that particular field of my motion, right? So in that motion where my muscles are contracted that much, I'm not able to maintain that retinal slip and I'll slide off. Okay. We went deep. We could do a whole weekend on that, done that in the past, but suffice it to say is now you can start to see how much vision and vestibular systems, and then, oh, by the way, if I do that with my head turned and I do the same thing, does that screw it up, right? And then now we start to really see how these things dance together, which is absolutely brilliant. And I think one of the most amazing things about trying to understand how these systems work together is actually doing the really simple stuff at the bedside, just like that. You can do it with a thumb and just directions, and just observing what people's eyes do can tell you so much about how these things are integrated. Like, for example, if we're in that same scenario, I can do this great. I can do this great. But then if I turn my head over here and then all of a sudden I come over, I might find that there's an error now. And so now that gives me a sense of like, oh, okay, so if I turn my head, there's something about that change that's going into that processor that my brain does not like, that messes with my signal. Or it could be saying like, I am choking myself when I turn that way, or when I use my shoulder, it's messing with my brain. And then you can just keep solving forward and using those layers to help you out. Cool. Great question, Nomad Nova Normal. For the rest of the team, that's probably a lot of depth. Sorry to go deeper, and we went way off topic, but I think it's for anybody that's trying to like get a sense of like, functional neurology, why it's useful, why it's different. That's probably a good reference point for understanding it. So it's not the same as like we just throw a pen and make sure your eyes work. We want to know the nuance of like when do they work great and what makes them start to fail. And then from that failure, you can kind of start pulling that string to see why it's failing. And that'll lead you to the homeland or what's wrong here. And then now if I know what's wrong, I can do stuff. I can start to say, how do I fix that? Is it strong enough? Are there things that I can do to make that better? And now we're on, now we're going. So hope that's useful for you guys. Cool. All right. Oh, thank you so much. Elsa says off topic and deeper explanations are brilliant. Please keep teaching us. You're going to make me blush. I really appreciate you guys. Same with Jennifer Caldwell, guest from a couple sessions ago. If you guys get a chance, go back and check her out. Really awesome stuff with what they're doing. down there in for our military teams. Thank you so much. All right, so we're on number 2 of 7. Woo! Let's do it. Here we go. Let's go to the next. All right, so number 3 things that we have to know. That we can get some headaches just from the neck strain. Oh yeah, forgot all about headaches, right? So not only do we have to think about our vision and the integration for dizziness and our balance, but also just the sheer fact that if I injure these babies, if I injure them, there is a probability of just creating irritation from mechanical shift, mechanical shearing, mechanical irritation is the right word. I should have just stuck with that one. And that irritation causes its own problems. You guys probably have heard of the fact that like people will get headaches from hanging their head, where they'll feel them kind of start in the back, where they call them tension headaches, right? Oh, my neck. Oh, I was working too hard at the computer. And that headache kind of tends to come up from the back of your neck, and it kind of comes around like your temple, and then goes behind your eye, right? So people can do that, or they might point or do this sort of thing. But that tends to be what's called a suboccipital headache. And if I get irritation in the muscles or in the joint, well, let me take that back. Irritation in the muscles will cause a certain type of musculogenic headache back there. We can also see that we have sclerotogenous pain referrals that come from the joints themselves that have their own referral. They feel a little bit more diffuse, like you can't point to where they are. And we can see a lot of these ones that kind of go around the back of the head, and they feel like they come around to the front from just the tension that's placed on the mechanoreceptors back there. So those are a really good indicator that something's up with my neck. Cool. So especially if you've had this injury, but also not only the neck injury, but then we work backwards and say, hey, if there's something going on with my eyes and they're banging around and I get that cervical colic response that's tightening my neck down, I might get like stiffness and soreness that's from that. And as a chiropractors that are on our squad here, you'll know these, especially my chiropractic neurologist buddies, like John Chung, great friend, great chiropractor, great chiropractic neurologist. Check him out. If you're in that boat, you know that even that problem with the eyes, I've got a convergent spasm. I'm not like when I read, they get all gnarly and I have a hard time looking up and I can't see right. You'll feel that same tension in your neck. Or if I've got a vestibular problem, you'll probably notice that stiffness in your neck, and there's a likelihood that you'll get that suboccipital neuralgia. So irritation in the neck itself causes problems, but then also anything that speaks to the same integrator could also cause the problem. I hope I'm punching that home. I'm going to feel like a broken record. But especially when we're in that top portion, C1, 2, and a little bit of 3, these are linked to the trigeminocervical nucleus. So we actually process these in the same place we process things similar to like head pain, right? So our head and facial pain, those all get processed together. So they're pretty sensitive down there, and they can mimic what looks like a tension headache. And some people, it feels like a migraine, or they might identify it as a migraine, but it's actually coming from dysfunction in the cervical joints. Cool. All right, next one. Big one for our crowd here, autonomic nervous system disruption. This has been one of the bigger inputs of my life, not just because it's as simple as like you injure your neck, it throws off your autonomic system. It's more in terms of like how profound the relationships are between your neck and just the transmission of energy, which is kind of what your autonomic system's in charge of. So we see, like we're going to talk about here, where I injure the joints, the proprioception problem itself screws up projections into the vestibular nuclei. The vestibular nuclei help us predict and program head movement. When we move our head, we have to be able to adjust the blood flow that's going into our head. So if I move it, but I'm not sure about what's going on, I can start to see problems with getting blood flow into my head. So I'll start to feel the problems that come with that we're going to talk about here next. But then we can also see changes in the descending outputs from the nucleus ambiguus, which has ties to the vestibular nuclei. We can see problems with the RVLM, the CVLM, all of these little processors in our brainstem that send out the signals that are automated and under control all the time. They're all tied to this dang vestibular nucleus, right? The MTS that processes the feedback of all of these is tied to the vestibular nucleus. Stuff all works together. So the same way I can have a vestibular problem or a neck problem that messes with each other, they're also likely to change things with the way I send signals to my heart. So it can cause palpitations, it can cause arrhythmias. We can see where you just feel that big thud in your chest. We'll talk about those later. But it can also cause digestive problems where I'm not able to maintain that signal of motility, and I'll start to see fits and starts with what's happening in the digestive capacity. A lot of you guys have experienced both of these things. And then third is temperature dysregulation. Same thing. I'm just not able to keep that sensory motor command, and my window of my thermostat just gets too big, right? That can happen just from the feedback to the brainstem part alone. Then throw in things like if that joint isn't moving correctly, I have a probability of causing compression or shear into the vessels that are going not even in my spinal column, but in exterior to that. So I can cause carotid or vertebral compressions. I can cause internal jugular vein compressions. I can cause vagus compressions, all sorts of things that are just external as a function of just cutting it off because they aren't moving correctly. Okay, so big deal. It's like been the thing of my life to understand that it's not just the proprioceptive signals. It's not just the compression that's happening from the instability of it moving too much. It can be related to how all of these things operate together, which is what makes them challenging for people to hunt down. Okay, I'm going to take we got a couple more little comments here. Dr. Ginia hanging out. Pro hunt. Love that. My brain has changed over time. Can't think through my frontal lobes and my middle lobes. Back, my eyes are being affected. I have not had a spine injury, haven't had a scan, no pinched nerves. So it sounds like Pro Hunt, love to be able to help you. Would love to know kind of more about this. Says tried everything to stop the blood pooling in my hands. And like you said, it's like a broken motor system. I really appreciate you taking the time to try type this out. I've changed my entire body physically and mentally. CT for my head was fine. EpiPens, Benadryl, did a great deal to get my autonomic system to function. Yeah, so these are ways where you're kind of thinking of the end organ, right? What I'm suggesting is maybe even though we can't see it on a CT, there's a high probability that we can still have errors within that system. So keep hanging with us, keep learning, and maybe that can give you the opportunity to figure out some of these things either for yourself with some help. Obviously, we're here. We're always here. I don't use this as a way to be able to say, come see us, but we're obviously here to try to help as much as we can. Yeah, normal over nomad, or nomad over normal. So thanks for the questions. I appreciate you. Oh, yes, peace. Peace, love, Mung Bean. Back for more. How do jaw problems fit in? So the jaw, we just talked about that trigeminal cervical nucleus. They're all tied together. So the proprioception of your jaw is managed by the superior trigeminal nucleus, which is the mesencephalic trigeminal nucleus. And that gives you proprioception of your jaw, which is tied to proprioception of your neck, especially in the upper cervical spine. So one thing that some people will notice is that if they're in a position that is not happy for them, especially for like whiplash folks, and you stay there for a while, you might notice that when you bite, your bite changes, your teeth don't line up, or you're biting your lip, or you're biting your cheek, just from changing positions of your neck. So if you reciprocate that and you say, I got punched in the jaw, and I'm getting this strange feedback in my jaw, that might also impact the relationship with your neck. Great point. All right. Kelly, can it also trigger and worsen SVTs? My sister's really started having trouble with that. Telling other symptoms and body structure that is similar to Callie's as well. You guys probably don't know Callie's body structure. But yeah, so SVT stands for supraventricular tachycardia. What does that mean? It means if I got a heart, there's a top part and a bottom part. So if you think about a heart, you don't even have to think about it in the normal way. You can just divide it up like this, like that. And you just got a top part. These are the atria. And you've got bottom parts, which are the ventricles. And basically the atria serve to dump into the ventricles. It's like a little, what's the word I'm thinking about? Like a vestibule. We have them up here in the cold where you've got like a little room when you first walk into a restaurant or a building that like helps control the temperature so it doesn't freeze out the rest of the restaurant. That's like a vestibule. That's what your atria are like. And they dump into the ventricles. So if as blood comes into the right atria and then down into the ventricles, then that goes out the back here to the lungs, and then it circles back to the atria, to these ventricles, and then back out to the body. So atria to the ventricles. So if I have supraventricular tachycardia, it means that I'm having tachycardia that is initiated in the atria. There's kind of the normal flow where we had this node here called the SA node, sinoatrial node. All of the inputs from your brain kind of come here, and that sets the pace of your heart. And then it kind of, there's like a little slowdown. And then we have an AV node here, and that allows us to kind of slow the processing down. And then that signal transmits up the ventricles. So that way, when it comes in, there's a little delay between the atria and ventricles that allows you to have this. So it moves the signal like that. So if I have tachycardia that's coming from the top, the questions that you would have are, is it happening because we're getting a spread of the node in the atria where it's not using the normal highway, it's kind of going off road? That can be a thing that happens. And you can see that on an ECG. You'll see these little errors in the way that the waves are formed. But then also it can happen if there's irritation at the SA node, which can come from changes in outputs from the two vagus nerves and the two sympathetic chains that come in. They all go into a cardiac plexus, and all of that is integrated just like in your vestibular nucleus, but it's at your heart. And if that signal isn't doing hot, then we can see that it can irritate the SA node, and we can have these depolarizations that happen as well. Typically not so much in the AV node. So those are kind of the two like big things that we're looking at. Is it going off road, or is it getting irritated in a way where we're not holding that steady? Also, if there's too long of a pause between the beats, like the heart rates are going too slow, sometimes we can get reentrant beats where it's not tachycardic, but it actually becomes a problem with arrhythmias. So the tachycardia means that we're more likely overcooking that SA node and we're causing too many beats to happen. Is it going off road, or is there a problem in the descending portion here? So I think you're on the right track with the way you're thinking about that. I love it. Okay. So, Irene, does the vestibular nucleus affect CFS or PEM? We're going to talk about that in a little bit. Okay, hang with me. I know I've gone off topic and we've gone a while here. Okay, so Eileen is talking about some nuca and some upper cervical. So we're gonna all keep hoping for Eileen, hoping that she finds her way through with that. Let's cheer her on, root her on, send her a little note, give her some love. Let's keep her going. Should everyone be using a posture pump or doing Brugger's exercises, since we all have tech neck, to try to get in front of it? It's not a bad idea. So what we're talking about here, posture pump is a thing you can lay down on, give it a little squeeze, and it pushes your neck forward and helps you kind of reestablish a curve. It can be a really good tool. Other ones like it would be things like a Denner roll or a cervical wedge. Those things are really useful. All they are is you're just countering hours spent like this with some time spent in the opposite direction. Same as if you were like always like this, you might want to stretch and open up here. And that gives us to the next point, which is a Brugger's exercise, which is where we actually, can I get back far enough? Yeah. So I can let my shoulders down. I sit up super tall, and I'm going to take my palms up, thumbs back, elbows in tight, and push them back here. What you might notice that even people that feel like it's in your neck, a lot of times we start to get this rounding back here. And by pulling those shoulders, it actually stacks your neck back up. Super important. You just hang out like that as long as you can. take a break, and you're just working on those muscles in your back and opening up across the front of your shoulder. But it's a really interesting point, because when we talk about cranio-cervical instability, which was originally what we were here to talk about, we blame it on this upper part because that's where the motion is. But the reality is a lot of our motion is designed to come in that area. But what can happen, especially in this flexion and extension component, is if I'm really stiff back in here, which is what happens like this, and I roll these babies forward, my shoulders, well, what can happen here is I'm actually going to be compensating for that roll forward by having to create more activity in my upper cervical segment. So there was a good study that was done where we actually looked at mobilizing in the lower cervicals helped with the stability of the upper cervical segments, because they're not having to compensate by overacting or creating instability, as it's referred to. Hang on, we got Dr. Claire here. Okay. Got to check those when they come through always. Okay, but my point being, if that happens and I'm rigid, I'm going to have to create some hypermobility in other places. And this can be one of the things that we confound, and we jump right to doing stuff up here. I'm going to tighten this up. But if I don't fix all of that underlying component, it's not going to do anything anyway. All the exercises you do, all the Prolo you inject, it's not going to do anything, because you're just going to break the structure down more. So that's a really good point. Everybody can do those at home. Anything that pulls your shoulders back, tips your head back. If you're a person that's just here all day, it's going to feel good, number one. And just being able to do that, you probably can't hear me, but being able to do that can offset some of the long-term effects of being there. And I believe it was Dennis that was asking about tech neck. That's what we're talking about, as like a very simple strategy. Cool. All right, we've got Dr. Habanova. Am I saying that right? I feel like I got to put a little flair on it, but it's good to see you. Hope you're doing great. Thanks for being here. And Jen Caldwell, following up on the TMJ, CCJ impairments, is it correct to assume that clenching really hard could also be a compensation for ocular or vestibular issues due to proprioceptive inputs, especially if it's on one side? That can definitely happen. The same way you can have dystonia, where you get a tight muscle. You can have tightness in the jaw, whether that's in the masseter or whether you're kind of getting internal and we're having to pop the finger caught on and get after those. So you can see that, especially when you look at the deviation of the jaw. We're getting a little inside baseball for everybody, but people will tend to brux more. But that can also be a component of that midbrain, where we get hyperactivation there and we'll create the bruxism. In these cases, we'll also tend to see hyperactivity with what's happening with the eyes. You may see these square wave oscillations, or you may see more breakdowns in the vertical eye movements. Those are little indicators that go with that bruxism. And you'll see that you may have development of the jaw change, and then we have somebody tilt back. This may be super, super tight. And you may notice that there is impairment in some of the musculature in the anterior neck. So definitely something to keep an eye on. And you'll notice that, especially if you have people tip their head back. So we like to do this where I'll anchor on their sternum here, like that. And then you're not pushing, you're just using the weight of your hands. And if you tilt your head straight back, you'll feel like a big stretch there. And then if you try to close your teeth, you'll get a sense of where that pull comes from, because as people try to close their teeth, they might feel like different tensions or pull, or they might not actually be able to even close their teeth. So you just start off there, open, and then close, and you'll feel if there's an asymmetry, or the person, if you try that right now, you'll feel if there's an asymmetry with the way you close. Cool. And on the same issue, Eileen says, I told to keep the tongue to the roof of my mouth for strength. That can be a really good tool. Not just even sometimes people say the tip to the roof of your mouth, and that'll help to stimulate down here. But even just pushing your tongue flat against the top of your mouth and like expanding it against your teeth can give people some relief as well. That's a good tip. Good tips. Thank you, Callie. It's good to see you on here. Hope you guys are doing well. Corey, I've read COVID has the ability to change muscle fiber types throughout the body through direct infection or other inflammatory pathways. Yes, I imagine this is significantly impacting the neck. Yeah, we're getting into some wild stuff here in our COVID research. I'm glad you're on that. There's some interesting things. It's always tough to talk about it in these scenarios because you're going to get afraid to get strikes sometimes. So like you don't know what to talk about. But yeah, so even changes in muscular activity, it's wild. It's wild. Yeah, take care of yourself. Stay healthy. Get in the sunlight. Get some exposure to some clean, fresh air. Drink some clean water. Eat some clean food. Try to keep the chemicals out of you. That's a good advice, I think. But yes, fiber type changes, but also inflammatory changes within the muscles. We talk about myocarditis. What does that mean? The myocardium is the muscle cell of the heart. So myocarditis is a thing that we've seen plenty of when it comes to COVID or the amelioration product of trying to solve COVID affecting that myocardium. But it's muscle tissue. It's a different type of muscle tissue. It's got a different structure to it. But also, it's not a far stretch to consider how we might start to get myositis, which is a common thing. And that myositis can come not just from COVID, but other types of infections or other types of interventions as well, where we'll see more chronic types of autoimmune myositis develop. And that's kind of a key point here. So when we think about the relationship of these to neck function and movement, now you can see how that could kind of start to evolve into these other symptoms where I'm getting dizzy, I'm getting fatigued, I'm getting foggy, I'm sore. And now we're in the world of not only COVID, not only autonomic function, not only concussion, not only brain injury, but now we're in the myalgia, encephalitis, chronic fatigue boat here, where you start to see these things start to snowball on people. Okay. So great questions, great comments for everybody. I love it. I'm only 4 in. I don't even know what we're talking about anymore. We were supposed to be talking about cranio-cervical joint dysfunction, but I'm having a great time. I hope you guys are having fun. Let's get back on it. Let's see what number 5's got in store for us. I'm gonna just delete these so it doesn't become a permanent part of the slide. All right, you ready? Here we go. So number 5, trouble thinking, aka the old foggy brain. I spend a lot of time every day, as you guys know that are here, talking about foggy brains and this like thick thinking, difficulty thinking, formulating words, creating memories, being able to think through any sort of complexity, and the fatigue that can come from that. Just simple conversation, going to a restaurant, being able to process all the information that's coming in, right? And I think this first sentence here really really highlights what that is in my language, is this noise. We talk about noise from overactive sensors. In this case, we're talking about the neck, but now you can see where those other sensors could be problems too. So maybe I got a problem in my neck and it's just always creating